السلام عليكم.
عليكم السلام.
So today we're going to start our academic activity, inshallah. So first lecture, it's going to be about the anatomy and pathophysiology of tricuspid pulmonary valve, and it will be presented by Dr. Riyad Al-Harthi. The panelists today will be Dr. Khalifa Al-Anizi and myself, Dr. Abdurrahman Al-Waili. Dr. Riyad? Dr. Riyad?
Yeah.
Are you ready?
Yeah.
Okay, let's start.
السلام عليكم. رياض الحارثي, King Fahd Armed Forces Hospital, Jeddah. Anatomy and pathophysiology of tricuspid and pulmonary. Tricuspid valve consists of three leaflets: anterior, posterior, septal, chordae tendineae, two discrete papillary muscle, the fibrous tricuspid annulus, and right atrial and right ventricular myocardium. The anterior leaflet is the largest, the septal leaflet is the smallest, and right is medially directed directly from tricuspid annulus above the interventricular septum. The posterior leaflet often has multiple scallops. Tricuspid annular sizing has been based on dimension of the base of the septal leaflet. The anterior papillary muscle provide chordae to anterior and posterior leaflet. The medial papillary muscle provide chordae to posterior and septal leaflet. The septal wall gives chordae to anterior and septal leaflet. There may be accessory chordal attachment to the right ventricular free wall and the moderator band. Right ventricular dysfunction and dilation lead to chordal tethering, contributing to loss of the leaflet apposition. Dilation of the right ventricle results in tricuspid annular enlargement, primarily in the anterior and posterior mural aspect, resulting in significant functional tricuspid regurgitation. During the cardiac cycle, there is approximate 20% reduction in annular circumference and 30% reduction in annular area with atrial systole. At healthy subjects had a non-planar elliptical shaped tricuspid annulus with posteroseptal portion being Lewis toward right ventricular apex, and the anteroseptal portion is the highest. Patients with FTR generally had a more planar annulus, which was dilated primarily in septolateral direction, resulting in more circular and flat shape, as compared with elliptical shape in healthy subjects. Clinical presentation: the most common presentation of TR is secondary to cardiac valvular pathology, mostly mitral valve disease, as pulmonary hypertension default leading to right ventricular dilatation. The tricuspid valve annulus will dilate. The circumference of annulus lengthens primarily along attachment of the anterior and posterior leaflet. The septal leaflet is fixed between the fibrous trigone, preventing lengthening. Progressive annular and ventricular dilatation, the chordal papillary muscle complex become functionally shorted, causing leaflet tethering. This combination prevents leaflet apposition, resulting in valvular incompetence. Eisenmenger syndrome and primary pulmonary hypertension lead to the same pathophysiology of progressive right ventricular dilatation, tricuspid annular enlargement, and valvular incompetence. A right ventricular infarction produces either disruption of papillary muscle or severe regional wall motion abnormality. Marfan syndrome and other variations of myxomatous disease affecting the mitral and tricuspid valve can lead to prolapsing leaflet, elongation of chordae, and chordal rupture, producing valvular incompetence. Dilated cardiomyopathy in late stage of Biventricular failure and pulmonary hypertension produce TR. Infectious endocarditis can destroy leaflet tissue, mostly in drug addict with staphylococcal infection. The carcinoid syndrome leads to deposit of fibrous tissue in the endocardium of valve cusp, cardiac chambers, intima of great vessels, and coronary sinus. Effect of tricuspid permanent pacemaker or implantable cardiac defibrillator worsened by 1 grade or more, and the TR worsening was more common with implantable cardiac defibrillator than permanent pacemaker. The current guidelines do not recommend lead extraction for patients with exhausting of TR and tricuspid pacing lead. Tricuspid regurgitation. Rheumatic disease of tricuspid valve is always associated with mitral valve involvement, and deformity of the tricuspid tissue result in tricuspid valve stenosis as well as regurgitation. And this is a table of causes tricuspid regurgitation. You can see primary cause 25%, like rheumatic myxomatous epistian, and secondary 75%, like left heart disease, pulmonary hypertension, or any cause of RV dysfunction. Symptom of fatigue and weakness related to reduction in cardiac output. AF is common, jugular vein distension is found, right side heart failure lead to ascites, congestive hepatosplenomegaly, pulsatile, liver, pleural effusion, and peripheral edema. In the late stage, these patients are worsened with cachexia, cyanosis, and jaundice. Hepatic cardiac cirrhosis can develop in neglected case. Echo is routine used to assess severity of TR in clinical practice. Pulsed Doppler and color flow study help to identify systolic right ventricular to the right atrial flow. The tricuspid valve in carcinoid syndrome is thickened with retracted leaflet fixed in semi-open position throughout the cardiac cycle. Tricuspid stenosis, most commonly rheumatic, extremely rare to have isolated TS because some degree of TR will be present. The anatomical features are similar to those of the mitral stenosis with fusion and shortening of chordae and leaflet thickening. Fusion along free edge and calcific deposit on the valve are found late in the disease, the majority of cases in young women. The diastolic gradient between right atrium and RV is significantly elevated, even 2 to 5 mm per mercury mean pressure. As the right atrial pressure increases, venous congestion leads to distension of the jugular vein, ascites, pleural effusion, and peripheral edema. Over time, the right atrial wall thickness and atrial chamber dilates. Clinical features are consistent with reduced cardiac output, producing symptom of fatigue, malaise, significant liver engorgement, produce right upper quadrant tenderness with palpable liver with pre-systolic pulse, ascites, peripheral edema, and anasacra can default. Sphericity may mask or reduce pulmonary congestion of mitral stenosis, aiming to reduce blood flow to the left side of the heart. The low output state of the patient is prominent. The echocardiography reveals the diagnostic feature of diastolic dooming of thickening tricuspid valve leaflet, reduced leaflet mobility, and reduced orifice of the flow. The Doppler flow pattern across the tricuspid valve has a prolonged slope of antegrade flow. Functional tricuspid regurgitation, secondary tricuspid regurgitation, also called FTR, may become worse over time, leading to severe symptom, biventricular heart failure, and death. Pulmonary arterial hypertension from any cause is known to be associated with development of secondary tricuspid regurgitation. Increased pulmonary artery systolic pressure was independently associated with greater degree of TR. Other factors such as AF, pacemaker lead, and right heart enlargement were also importantly associated with TR severity. Surgical treatment of left side valvular lesion is not always adequate to resolve or prevent progressive TR. This is especially true when pulmonary hypertension persists. Pulmonary valve. The outlet portion of the right ventricle consists in fundibulum, a circumferential muscular structure that support the leaflet of pulmonary valve. Because of the semilunar shape of the pulmonary valve leaflet, this valve does not have annulus in the traditional sense of ring-like attachment. The leaflet have semilunar attachment that cross muscular arterial junction in corresponding semilunar fashion. Instead of single annulus, three ring can be distinguished anatomically in relation to pulmonary valve superiorly to the sinutubular ridge of pulmonary trunk mark the level of peripheral apposition of the leaflet, the commissures. A second ring exists at the ventricular arterial junction. Third ring can be constructed by joining together the basal attachment of the three leaflet to the infundibular muscle. None of these rings correspond to the attachment of the leaflet. These similar attachments, which mark the hemodynamic ventricular arterial junction, extend from first ring across the second down to the third and back in each aspect. This is my reference, and thank you.
Well, thank you, Dr. Real, for the lecture. So, as was announced before, the surgical tricuspid repair and replacement lecture was postponed to another time. So we'll start with the next lecture. I don't know if you guys want a 10-minute break, or we can start على طول. Dr. Sireen?
We can start a new lecture.
Okay, Dr. Sireen?
Yes.
You're ready? Ready to go?
Yeah, I'm ready.
Okay, start.
Okay. Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. This is Sireen Murshid, R1 in Al-Medina Cardiac Center. I will talk about transcatheter tricuspid valve replacement. Our outlines will be introduction, principle of performing transcatheter tricuspid valve replacement, outline the challenges related to this procedure, analyze the devices that can be utilized. This is a brief introduction. Tricuspid regurgitation affects 65 to 85% of the population, so it's not a rare disease. It's two types, primary and secondary, or functionally. The primary divided into two categories according to the cause, congenital or acquired. The congenital, like in Epstein anomalies, atrioventricular defect, and myxomatous prolapse. The acquired type caused by endocarditis, rheumatic disease, carcinoid, flail leaflet caused by trauma, or from pacemaker leads implantation. The secondary type, which is more common and causes significant tricuspid regurg, the pathophysiology of its structural abnormalities of the tricuspid valve apparatus, which happen as a subsequent to left side heart disease, like a left side heart failure or mitral or aortic valve disease, pulmonary hypertension, or a primary cause from pulmonary cause. These causes annular dilatation and subsequent leaflet tethering, causing malcoaptation of the valve. These are some facts I found it interested to share. Surgical tricuspid valve repair is the most common form of tricuspid valve surgery, and usually combined with another major surgical procedure. isolated tricuspid valve surgery have a high mortality rate of 8.8%, the highest risk of all surgical valve intervention. In patients with severe right ventricular dysfunction and severe pulmonary hypertension, we should consider transcatheter valve replacement rather than surgical replacement to reduce the risk of afterload mismatch by avoiding factors like cardiopulmonary bypass and cardioplegic arrest. The symptoms is mentioned already. It's a symptom of right side heart failure. In patient selection for tricuspid valve replacement by transcatheter approach, to do a valve replacement rather than a valve repair in patient with fibrotic leaflet as a result of carcinoid syndrome or rheumatic disease, large coaptation gap from 6 to 8 millimeter and non-central regurgitant jet. If the residual tricuspid regurgitation is expected to be moderate or severe after the repair, we're going to go to replacement. Tricuspid valve stenosis, and in patient with extremely dilated annuli with or extreme leaflet tethering. Access selection. Tricuspid valve annulus is a large and larger than mitral valve annulus, and if it gets diseased, that means it gets larger than normal. So we need a large caliber access to insert a prosthetic valve through without getting the vein damage. The safest access, it's a femoral vein access, but its limitation in a steep angle. Transjugular access, it's a good angle, but we need to make sure of large caliber vein to not get the vein damage. And transatrial approach, it's a surgical approach by anterior thoracotomy with direct access. Valve anchoring, the tricuspid valve, it's a self-expanding device effect and with lower risk of annular stretching and damage. So the self-expanding devices, it's more benefit so to not get damaged the structure around. Tricuspid valve prosthesis is associated with a lower risk of outflow tract obstruction. So no need for active grasping of the native tricuspid leaflet. Those can help in anchoring the valves. Improper anchoring may lead to device malfunctioning, paravalvular leak, valve embolism, or valve thrombosis. Interaction with conduction system and pacing device. AV node and bundle of His are near to the commissure between septal and anterior tricuspid leaflet, as in the picture you can see here. So after the valve implantation, if it's getting stretching of this area will cause arrhythmia. So we're gonna need the permanent pacemaker, which can be affected by the prosthetic valve implantation itself. Potential complication of transcatheter tricuspid valve replacement. When the tricuspid valve regurgitation completely resolved and an acute increase in afterload on the right ventricle may lead to worsening of right heart failure. The second complication is lifelong anticoagulant use due to high risk of valvular thrombus information because of low blood velocity in the right ventricle, and can be switched to dual antiplatelets after 6 months. Using the imaging studies, it's very important before, during, and after the procedure of transcatheter tricuspid valve replacement. The gold standard, it's echocardiography, either transthoracic or transesophageal. We can assess tricuspid regurgitation severity and its etiology, as well as the right ventricle function and pulmonary pressure. CT used for tricuspid valve structural evaluation and measurement of right ventricle dimension and tricuspid valve annular size and relation with the right coronary artery. Cardiac magnetic resonance also can be helpful. Pre-procedure requires measurement of the inferior vena cava and iliac vein. As I mentioned, it's a large valve, so we need to measure the caliber of the vein to make sure that it's accommodate delivery of the catheter, so not to get the vein damage. Okay, we're gonna move to the devices used in transcatheter tricuspid valve replacement. The first one, which is used those days, it's gate. This is the one. Okay. As I read, it's by transatrial approach, but can cause bleeding complication in high-risk patients and increase hospitalization. So they are started to use it as a transjugular access. It's a self-expanding valve stent. It's made of nitinol alloy stent, into which is mounted a tri-leaflet valve fabricated from echini pericardium. Engaged the TV annulus and TV leaflets from both inferior and superior aspect, designed to match the dilated tricuspid valve annulus, typically for the secondary or the functional type of tricuspid regurg. Stable engagement of the native annulus with excellent hemodynamic and valve performance. Successful valve implantation in all patients with successful tricuspid regurg reduction, 30 days follow-up post-procedure. An important consideration is the device oversizing by 5 to 10%, so it helps in better sealing of the valve. The second type is trisol prosthesis. It's elastic nitinol frame and an inner valve apparatus. The frame is anchored by the annulus by multiple arms to secure the bioprosthesis into the native leaflet, tricuspid valve leaflets. Outside skirt seal the valve and prevent paravalvular leak. The leaflets close in a dome-shaped structure that increase the right ventricle closing volume to prevent the acute surge in afterload and to better accommodate the concomitant right ventricle dysfunction. The third type is EVOC type, was initially developed for mitral valve position, recently performed with successful implantation being achieved with mild paravalvular leak, showed in the echocardiography post-op. Follow-up clinical improvement to NIHA class 1. Recent data experience was published, including 25 patients with 92% technical success and improvement in clinical and echocardiographic parameters at 30 days post-procedure. The other types, it's still not used, but still under trials. Cardiovalve, double-framed valve with tri-leaflets, bovine pericardial leaflets. This valve showed early promise in first in human studies following mitral valve implantation via transseptal approach. Now its trial, it's currently underwent in US. V-dyne valve, porcine inner valve encased in an outer annular ring via transfemoral sheath. This valve offers a pop-off mechanism in the event of afterload mismatch. Lux valve, it's a 4 components valve, a bovine pericardial valve. It's a self-expanding nitinol valve stent with an atrial disc, an interventricular septal anchor tab, and 2 graspers. Delivered via right thoracotomy. In 35 patients treated, implantation success rate was 100%, and all were alive at 30 days post-procedure. Right ventricular volume, 6-minute walk distance, and NIHA classes were all significantly improved after the procedure. The last one, it's Intrepid valve, originally developed for transcatheter mitral valve repair, 3 annular size, boiled around a single 29mm bovine valve that is delivered via transfemoral access. Early visibility trial with Intrepid for transcatheter tricuspid valve replacement is about to start in US. Okay, at the end, the question is which valve to consider in transcatheter tricuspid replacement. It's depend on the it's depend on the structure and measurement and causes of tricuspid valve regurgitation. For example, in severe functional tricuspid regurg, it will be a large annular size, so we're gonna need a large prosthetic valve, which be available in cardiovalve and evoke valves. So we're gonna use one of them in the procedure. So at the end, it's depend on the anatomy and structure and evaluated by imaging studies. And these are my references. Thank you so much. If anyone has any questions.
Well, thank you so much, Dr. Sirine. Any question from the audience? Well, I think we finished our academic activity for today. Thank you everyone for attending.